Good evening, everyone. Welcome to this week's installment of the National Fellow Online Lecture Series. My name is Samantha Mazzeo. I am a sports medicine fellow at Mount Sinai Hospital in New York City. I will be your moderator for this evening. This is a lecture series sponsored by our Fellows Online Education Subcommittee through our Education Committee at AMSSM. We're excited to welcome Dr. Craig Rudy this evening to talk about upper extremity trauma. But before we begin the lecture, some housekeeping items and announcements. The goals of this lecture series is to be an adjunct to your home program's educational content. We hope to provide the fellows with direct access to educational experiences with AMSSM members and at times invited guests. We hope to assist in the fellows' CAQ exam preparation. In order to optimize this educational experience, we invite you to share ideas on topics and speaker suggestions so we can represent all topics, regions, and specialties. To do this, you can go to the amsssm.org website and use the dedicated form, instructions shown here, or you can scan this QR code, which will take you directly to the form. As a reminder, the goal of this lecture series is to provide CAQ preparation for fellows. Please keep this in mind when providing feedback. Additionally, one other announcement regarding our AMSSM Library of Sports Ultrasound Pathology. This is a collection of sports ultrasound pathologies, and any attending or trainee can submit cases with high-quality images. It could be common or rare pathologies, both are welcome. These cases are published to the AMSSM website, and this could be added to your CV as a publication. You can scan the library link here, and questions you can email Dr. D'Amico or Dr. Kirsten with the email seen here. Before we get into our topic for tonight, I want to remind everyone of next week's lecture. We'll be joined by Dr. George Champas for a lecture on medical care during travel, and this session will be moderated by Dr. Melody Robes. Lastly, some rules for this evening. We ask that you mute your device's microphone and turn off your video. You may submit questions at any time through the chat function. Feel free to include your name and program if you wish, but not required. At the end of the lecture, I will moderate the questions submitted through the chat. And again, please remember to share any feedback you have with us at the end of the lecture. I'm happy to introduce Dr. Craig Rudy. Dr. Rudy is a board-certified emergency medicine and sports medicine physician practicing in Portland, Oregon, completing all of his training at OHSU, medical school, residency, and fellowship. He now splits his time between a community emergency department and an academic sports medicine practice. His clinical passions lie in sideline and event coverage, as well as teaching others about emergencies in sport. When not in the ED or on the sideline, you'll likely find him snowboarding or spending time with their family. Please join me in welcoming Dr. Craig Rudy, who will be lecturing this evening on upper extremity trauma. Dr. Rudy, feel free to share your slides. Thank you so much.
All right, hopefully you all can see this okay. So I'm honored to be here. Thank you for having me. We're going to talk about upper extremity trauma tonight. I don't have any disclosures. Broadly, this is a pretty large topic that's going to cover a lot of ground. We're mostly going to spend a lot of time talking about fractures, dislocations, acute traumatic injuries. We unfortunately are not going to be able to cover a lot of soft tissue injuries, but we'll talk about some that may be associated with some of our other injuries. A lot of my focus is going to be on hyperacute management when you see the injury, but we'll talk about some of the longitudinal care. We're going to dive right in with shoulder dislocations, and there are three broad types of shoulder dislocations to talk about. First is the anterior, which is going to dominate most of the dislocations you see, but there will be a discussion on posterior and inferior dislocations as well. Anterior dislocation is commonly what we think of when we discuss dislocations. About 95% of dislocations are going to be anterior. They tend to be a kind of a bimodal distribution, mostly in the 20s, but another peak somewhere around age 60. Most are a FOOSH mechanism, a fall on an outstretched hand, which is going to be a really common acronym tonight. You will sometimes see these with a posteriorly directed force while the patient's in external rotation, but it's pretty uncommon. The question of pre-reduction imaging comes up a lot. In my opinion, it really depends. I think a lot of textbooks will say to do it on the first dislocation, but I think context and environment really matters. I've definitely been on the sideline covering an event and had a very clear dislocation that I had a very low suspicion for concurrent fracture and realized that the amount of time it was going to take to disposition this patient to get from the field to the ED, to get films, to identify the dislocation and get reduced, maybe hours, which complicates the reduction and really puts a lot of pressure on the tenocyte, or excuse me, the chondrocyte. So in my opinion, it really depends. Once someone's in the ER as a first-time dislocation, I frequently will get an X-ray, but again, it doesn't have to be. If I have any concern for concurrent fracture, then I'm probably going to get an X-ray first. Recurrent dislocators with a classic story, I may not get a pre-reduction film. I will always do a neurovascular exam, pretty special attention to the axillary nerve when I'm doing these, because that tends to be the most commonly involved, but I will do a complete neurovascular exam every time, pre and post my reduction. And then recurrence is going to be really high in young athletes, whereas our older patients are going to have a much lower risk of recurrence. I have an image that I borrowed from Ricky Sports Medicine, and this is a pretty classic appearing anterior dislocation. You'll see a squared off humerus. You'll see the humerus is pretty obviously drop down, anterior and inferior. The patient holds their arm in some degree of internal rotation. They tend to hold their wrist, sometimes their elbow, and they hold it in adduction. This is a pretty classic looking appearance. Before we kind of talk about reduction techniques, I really want to share a slide that is from an Annals of Emergency Medicine article. And this one takes a little bit of time to look at and think about. But to me, I think it's always really helpful as a cognitive framework. As a learner, there were so many techniques that were shared with me, and I always found them so confusing to remember all these different eponyms. I think the most important is pick one or two that you can be reliably good at and you can reproduce. I don't know that I have a framework that says that one is superior to the other. I will say the Coker is really out of fashion because of high risk of concurrent humeral shaft fractures. Similarly, I don't see the Milch very often anymore. But this framework really helps me kind of identify what is the goal of our mechanism. Globally, if you look towards the top, everything's going to be greater movement. As you move to the bottom, less movement. You'll see that there are probably two broad categories that I think of, mostly traction or a muscle relaxation balance type technique. There's scapular manipulation, which kind of lives on its own. Not very many people are doing leverage or rotation techniques anymore. My go-tos are usually these three in some order. I think lately I've been doing fairs mostly in the ED. And that one, as a reminder, is where you have the patient gradually abduct their shoulder from an adducted position at their side. You are doing all the work. It's very passive. With your gentle kind of shake of the extremity, there should be minimal traction, minimal pain. It takes minutes and probably painfully long for you as the reductionist to get up, but it should be painless. The patient shrugging their shoulder and moving their scapula, all of that abduction is being done via the scapula, and then you're not going to get an effective reduction. So you really want a glenohumeral abduction maneuver. And I find that one to be pretty well tolerated pretty well in an awake patient. Similarly, the Cunningham can be done in an awake patient. And that one is where you sit across from the person. You hold the patient's hand kind of up on your shoulder, and then you have a gentle traction, really pretty minimal, on the anacubital fossa with one of your arms while using your other arm to massage the deltoid. You're trying to get all of those muscles to relax. And then finally, the Boss-Holzak matter. That's one that I actually teach to patients because they can do this on their own, especially if they're recurrent dislocators. This is one where they're seated with their knees and their hips flexed at about 90 degrees. They hold the affected hand from the affected dislocated shoulder on the same knee, just below the tibial tuberosity. Some of the textbooks or articles will actually show you the person getting their hands like taped together, which is a little barbaric. I usually just, if the patient can tolerate it, have them clasp their hands together. They gradually lean back with their body and use the force of their body to get some traction. And it's pretty well tolerated, especially in a recurrent dislocator. This is an X-ray series of a pretty common anterior inferior dislocation. So you can see pretty obviously dislocated anterior, and then you've got a scapular Y view, which is really the classic ED lateral view, where you have a pretty clearly anterior dislocated humerus. Here is an X-ray of a person who has a recurrent dislocation, and I think the big take home of these is to look for what else is going on. This patient was someone who's dislocated numerous times, and he came in after a bicycle crash, and he's got this small glenoid chip fracture that's this old avulsion fragment that's been floating around. And this gentleman takes minimal force to reduce. Unfortunately, he doesn't want to follow up with orthopedic surgery or pursue any stabilization procedures. Posterior dislocations are pretty uncommon, probably less than 5% of all dislocations. Lateral views are going to be critical here because your anterior views can be really deceptively normal. Your first clue on exam is going to be in a blocked external rotation. It's not infrequent that a patient with these can touch their ipsilateral shoulder with their hand and come across, which sometimes is a suggestion that you've had a successful reduction, and so you can be fooled into thinking that there's no reduction. So I always will check external rotation as well, cautiously, because if it's a freshly reduced anterior, it may actually try to go back out. And then finally, if you see a bilateral posterior dislocation, think seizure, electrocution, something else very high energy that was systemic. This is a classic light bulb sign. So anterior dislocation, and frankly, I think these will see me in the ER, and I may miss them sometimes. So a lateral view is really crucial. But what's happened here is this humeral head is really rotated, and it looks a little bit like a light bulb. And so it's a little bit subtle. And so I really think in this case, a lateral is what you need. So if you get a scapular Y view and it's not a good lateral, I really will push a radiology tech to go back and get another X-ray to be sure. Here you've got an axillary view, and you can see that the humeral head is perched on the glenoid posteriorly. And so they're dislocated posteriorly, not all the way off the humeral head, which they tend to be a little bit more perched when I see them. But it's so crucial how much that orthogonal view will help you. Ultrasound's pretty helpful in this case. I think most of you are pretty familiar with a classic ultrasound of the posterior shoulder with a glenoid and the humeral head with the labrum. This is a posterior dislocation where you can see this humeral head is really perched right on the back of the glenoid. And that's a really helpful diagnostic view. I've known some people to do these if they're not sure if it's been reduced and they can't get an X-ray at the bedside, and they've attempted before the sedation ends if they can kind of roll the patient. So that's sometimes a nice helpful adjunct. And then here's a CT of an unfortunately delayed presentation of a posterior dislocation. This person was out for a few weeks before we met this patient. He unfortunately needed to go to the OR for a locked dislocation. So this is kind of the downside of when these get missed. They've got actually a reverse Hill-Sachs lesion, and we'll talk about what Hill-Sachs is, but you can see there's a pretty big impaction fracture right on the humeral head. And then finally, pretty rare, luxatio erecta, pretty testable eponym. This is an inferior dislocation, less than 1% of all dislocations. They're pretty high energy. I tend to think of them as something very high energy, maybe higher than sport, like high speed motorcycle accident or otherwise. Be mindful that they sometimes require a two-step reduction. They're typically managed just with a reduction of traction, counter-traction, but sometimes they'll reduce to an anterior-inferior. So it's important to check and make sure that you get a complete reduction. And then finally, if you think that they're really a truly high energy, make sure that this didn't displace all the way into the neurovascular bundle, which is deep. And so I will do a really good neurovascular exam on these folks too. You can imagine just with this image, if the glenoid or the humerus really came out of the glenoid all the way inferiorly, how they could have a pretty significant neurovascular injury. Fortunately, that's pretty uncommon. Here's an X-ray of a high energy trauma, and the patient almost always has their hand raised above their head as though they're asking a question, which is a pretty characteristic and telltale finding. That patient, they really cannot adduct, then I'm pretty worried for these. Post-reduction, I always recommend repeating your neurovascular exam. Sling, maybe shoulder immobilizer. Sling is my most common, but maybe a shoulder immobilization if they easily reduce in the or redislocate in the ED, which I've seen a few times. Younger patients, I tend to immobilize a little bit longer if I'm really trying to shoot for a capsular stiffness. I generally am averse to any kind of joint stiffness, but in this case, I may derive a little bit of benefit. So this is kind of my personal practice. Older patients, I'm trying to get them out of the sling as soon as possible, a few days. And as soon as that pain starts to get into that reasonable range, I want them to start some pendulum exercises. Your concurrent injuries, the Hill-Sachs lesion is probably one of the more common ones. It's an impaction fracture on the posterior lateral humeral head. Right as you get a dislocation that comes out, that bone will get a dent in it. And then it'll be on the anterior side if it's a posterior dislocation, maybe up to 70% of the time. The other common lesion is the Bankart lesion, which is a labral tear with some capsular avulsion. Probably one of these two injuries is going to happen with a dislocation. Most of the time, I'm just doing a standard MRI for a Bankart lesion, but your institution, they may want MRAs. So I'd really work with your radiologist and your your surgeons to see what they want for diagnosis of the Bankart lesion. And then finally, the bony Bankart lesion is a pretty rough injury because not only do you have the labral tear, but you have a piece of the glenoid rim which has gone with it. These pretty much always require surgical management if there's more than 5% of glenoid loss, recurrent instability, contact sport athletes. Follow-up, I generally like to see these patients in about a week, get them out of the sling, check on how they're doing, start answering questions, and that's my first kind of touch and follow-up. Want relative rest from sport, but I put question marks next to surgery and sport because I think it's really situation dependent. I tend to think of these as being dependent on the circumstances of the patient. How good of a candidate are they for surgery? What is their sport? What are the demands of their sport? What are they at in the season? What's the risk of return? What's the potential benefit of return, maybe in a high-level athlete? But I'm pretty weary about returning these if they've got pretty significant concurrent injuries like Bankart, bony Bankart, or Hill-Sachs deformities. I generally want them to be able to protect themselves if they are going to return, but most of these are going to be held out for a period of time until their pain is better, they've got good contralateral strength. The other thing is if you send them for surgery, that's almost always season ending. So I really would work with your surgeons, with your athletic trainers, your PTs, and the patient and individualize your approach about what your plan's going to be. And then this is from a recent BJSM article, and this is an infographic, which I thought was pretty interesting. They did a Delphi process, and they really looked at what do they think the kind of clinical recommendations that were consensus for post-operative shoulder. And I think it's worth maybe spending time outside of this lecture to look at it because there's a lot of ground. But I think to me, it always was a reminder of how much heterogeneity, and it's hard to get so much agreement across so many of these things that we see so commonly. And the article, I think, is very interesting to look at what there's agreement on and what there's not agreement on. So moving on to elbow dislocations. So these are frequently somebody kind of reaching behind themselves with a bent elbow and fall onto the hand. Most of the time they're posterior. You tend to get some degree of contralateral ligament disruption. And then it's uncommon to get neurovascular injuries. Probably most commonly, I'll see kind of a light stretch injury of the ulnar nerve. They'll describe kind of paresthesias in the ulnar nerve distribution. They usually resolve fairly quickly after reduction. The last time I can remember seeing this, I held the kid in the ER for an extra hour after reduction, and by then his numbness was resolved. Rarely does it involve the brachial artery or the median nerve, but again, I think it's always good to document a great exam. Essex-Lopresti fractures are uncommon, but to rare. But I think it's important when you've got one of these dislocations, just make sure you examine the radial head and palpate and examine the DRUJ just to make sure we're not missing these. Because not infrequently when I see these in the ED, even if I order a 3-view X-ray, they're going to get a 2-view because that's all they can tolerate. I flipped through these because the first X-ray, if you really squint at it, you can figure out that there is an anterior or a posterior dislocation, excuse me. But the lateral is so much more helpful. And so it's always a reminder that one view is no view. Getting an orthogonal view is really helpful. These are pictures from a Gottlieb article, who is an emergency medicine physician, and he's showing a variety of reduction techniques. And I'll share with you my favorite. My favorite for the awake patient is the leverage technique, where I put my elbow in the antecubital fossa and I clinch their hand with my hand and interlock. This does require some matching of forearm length. So if there's a significant mismatch, it may be difficult. But generally, I use a lot of directed force right into that antecubital fossa as I leverage the forearm over. And it works pretty well, especially on a freshly dislocated elbow. I will sometimes reduce these on the sideline if I'm pretty sure there's no concurrent major fracture. If I have concern for a fracture, then I'm going to refer those. I have not yet tried this, but this is kind of a modified Stimson, like a Stimson for a shoulder reduction, where you're using gravity to hang and then a little bit of a kind of a milking on the olecranon to try to push it over. Most of my sedated techniques are going to look like this or like this, but some sort of counter traction that involves some displacement inferiorly. This is a similar mechanism which you could try on an awake position. And I have not tried this one yet, but it would be probably my rescue maneuver if leverage didn't work on an awake patient. Where again, I'm using my leg a little bit like a Captain Morgan for a hip reduction, if you've heard of that, in an opposite fashion for downward forces, I pull some traction. This is the terrible triad, and And these are pretty devastating injuries. These tend to need surgery. They tend to be pretty unstable. You've got a coronoid process fracture along with a radial head fracture. Whenever I see an unstable dislocation, so that's one that tends to just want to reduce back to a dislocated position right away, this is my first concern. If I'm pretty sure there's no terrible triad, then I worry about just a really significant UCL dislocation, in which case sometimes if I pronate those people, they actually kind of lock into place and then won't dislocate. I tend to immobilize people for 5 to 10 days. I think most guidelines will say do a posterior long arm splint. There's been times where I've done a sling, but posterior long arm is the preferred. I'm going to get repeat x-rays a few days out and then probably in a couple of weeks. I want to get early range of motion as much as possible in any kind of elbow injury, but especially these, because I'm going to lose terminal extension the longer I immobilize them. The unstable fractions, the dislocations, the non-terrible triads are going to probably need a longer degree of immobilization to scar down, whereas a pretty simple dislocation, I could probably get them out in maybe a week, especially if their pain's going down and they can protect it. The people who have unstable fractures or open fractures are all going to need to be referred for surgery. And then it really depends on the UCL. I've had a lot of wrestlers come in with elbow dislocations, and almost universally, they don't really want any kind of UCL reconstruction, and they tolerate that laxity fairly well. Versus if you had an athlete who happened to have an elbow dislocation and was a pitcher in baseball, they probably would want a UCL reconstruction if there was a lot of laxity. I don't think there's any guideline that I've seen that says to do this, but in my ED patients who are young athletes, when I reduce them, I usually will do a little bit of a UCL assessment compared to the contralateral side in the post-reduction phase. If I'm going to communicate with our surgeon and give them a little bit of a heads up, just where do I think their laxity is. The AC joint injuries, so these are very common. Again, this is going to follow the pattern of the foosh or a fall on an adducted shoulder. Someone is maybe getting tackled or falls to their side. These tend to be high energy trauma, contact sport, really usually young people, males more than females. There usually will be tenderness at the AC joint with or without a deformity. Your type 3s and 5s will show this piano key deformity. You push on the clavicle and it goes down and then it comes right back. And then if you're getting x-rays and it's unclear, the Zanka view is the view that looks at the clavicle. And what this is they'll tilt the x-ray with about 15 degrees of a cephalic tilt of the x-ray beam. We'll have an example x-ray. Sometimes bilateral can be really helpful. Reminder of the anatomy, so that the two ligaments that we're really paying attention to here is the acromioclavicular ligament and the coracoclavicular ligament. We typically classify these on the Rockwood classification. And you'll see the most common ones are these first three. Type 1, they're going to have an AC joint sprain, really no major disruption, going to be a little bit of tenderness. Type 2, disrupted at the AC joint, but only a sprain, so intact coracoclavicular ligament. Type 3, both are out, and your clavicle will migrate superiorly 25 to 100% of the coracoclavicular distance. The type 4, 5, and 6, I really thought were hard for me to remember. And I had a colleague, a mentor, teach me this BUD acronym, which is pretty widely around. But backward is type 4, upward is type 5, downward is type 6. So type 4, not only is it a type 3, the clavicle is drifted posteriorly. Type 5, not only is it type 3, but it is really significantly elevated. Some of your type 3s will look like type 5s, but what you'll see that's different on these is it's going to be 100 to 300% of the coracoclavicular distance. They're going to be really, really significantly elevated. And then type 6 is pretty nasty because these are going to be inferior. So this is a classic kind of bilateral AC joint view, which we can contrast with more of a Zanka view where it flattens the clavicle out and you can get a much better assessment. You can't really look at too much else, but the Zanka view is very helpful. Here's a type 3 dislocation. You can see that there is quite a bit of distance here. There's still a little bit of kind of overlap. And once you've looked at a few of these, you'd realize that this is probably not 100% of the coracoclavicular distance that's increased. I don't typically measure them. I tend to, honestly, most of my radiologists are really good and give me a good measurement or a distance, but this one is pretty eyeballed pretty well to a type 3. Our type 1s and 2s, I tend to put in a sling with NSAIDs, early range of motion. pretty short duration for type 1s versus type 2s, might need it for up to 4 weeks. We'll get out of the sling once they're pain-free. Type 3s are really controversial for surgery. The last time I looked at the literature for this, it seemed like there was pretty clear evidence that the surgeons are doing more surgery for these, but it's not clear if there's better outcomes. There definitely is improved cosmesis, because if you don't operate there, that clavicle will tend to be chronically have this kind of upward appearance cosmetically, whereas it's pretty well tolerated. Some patients will get a really significant clicking or instability sensation, so some of those patients will go on to get surgery. And then type 4 to 6, they tend to require surgical intervention. Your return to play, I feel like it's usually somewhere in the 6-week mark for the type 2s, whereas the type 3s tend to be more in the 12-week mark. Some of our contact athletes might type to operate for or opt for a surgical intervention for type 3s. And there are some circumstances where athletes are playing with these injured with padding in place. And that has to be an individualized decision. Sternoclavicular disruptions are pretty rare, but these are really critical injuries to find. They're going to be a pretty similar mechanism to an AC joint. What might be slightly different is sometimes there's a rotational element, so they don't fall directly on an adducted shoulder, but they have some rotation. And that theoretically causes the force to cause an anterior or posterior dislocation. Anterior, fortunately, is way more common because the posterior is really a true emergency. Either of these, I tend to refer on almost immediately from the field of play. I think they're very hard to diagnose with X-ray, so I think CT or ultrasound are your go-to imaging, and I generally do not recommend anybody reduce these unless there's a critical, clear ABC emergency, because these can have pretty catastrophic injuries if they're reduced. So I recommend going to the operating room with ortho. Cardiothoracic is usually on standby. This may be more of a theoretical concern, and there's some evolving kind of case series about that, but that is all really early, and maybe we'll change our tune in a few years. So this is what an ultrasound looks like. You really honestly can just put the ultrasound right on the sternoclavicular joint and take a look at it. This is a normal appearance, clavicle here, sternum here, sternoclavicular joint. This is a posterior dislocation. One of my colleagues' X-ray ultrasound images from a long time ago. This is a clavicle here, posterior displaced, and this is the sternum. And this is a catastrophic injury. This is a CT of a different patient. The clavicular head is dislocated posteriorly. There's a little bit of hematoma associated with it. And you can see pretty quickly why this would be a pretty big deal. Mediastinum, airway, subclavian artery is going to be up here somewhere. If there's any kind of injury that this is stable into, I do not want to create an unstable injury in the chest without somebody who can fix that in a hurry. Anterior, most of these can be managed non-operatively. Some people will get surgery for these, particularly if there's a lot of cosmetic issues or if there's clicking or instability. Unfortunately, those surgical stabilization procedures, there's kind of variable outcomes, and some people feel like it only lasts a few years before they get recurrent clicking and migration of that sternoclavicular or the medial clavicular head. Posterior, these almost always need to go to the OR for reduction, plus or minus stabilization procedures there. There's no clear evidence base for return to play, so it's all expert opinion, but most of these, I'm not going to get them back to any kind of early replay. Most of these are going to be probably in the 3-month range, but there's a pretty wide variability. Clavicle fractures, there is a whole host of these. We're going to mostly talk about mid-clavicular fractures, which are the most common. Again, a fouche and a fall on an adducted shoulder tend to be young people, frequently teenagers I see most commonly in my practice. Majority are mid-shaft, which are really well tolerated. I will always do a really careful exam to look for skin tenting, because that can cause a delayed open fracture if there's skin necrosis and really negative outcomes. A careful neurovascular exam. And then if there's any high energy trauma, car accident or otherwise, I'm going to do a pulmonary exam, mostly because I'm going to be looking for an occult pneumo, maybe from an associated rib fracture. And it's very unlikely that the clavicle has actually gotten into the chest, but I think it's still reasonable to listen. This is a picture of a mid-shaft clavicular fracture with minimal displacement. It's pretty well tolerated. These can be put in a sling and sent for follow-up. These do not usually need surgery. Whereas this is a multi-part fracture with a displaced fragment with significant overlap. This is a significant injury. This person would need a surgical intervention. Those that are managed non-operatively will be in a sling for 4 to 6 weeks. Children maybe even shorter, 3 to 6 weeks. I've had a couple recently who I brought them back at the 5-week mark, somewhere in there, and then the patient was not in a sling, and the parent told me, "Oh yeah, they stopped hurting and they won't wear the sling anymore." And it's really hard to keep them wearing the sling. It's usually a pretty good sign that they've achieved some clinical healing. Usually around that point, when I think they've got some clinical healing, I'll get a repeat X-ray to look at the bony callus. I probably will not return them to sport for another month or two from there. And then if there's multi-part fracture, significant displacement, malunion, I'm going to send those for surgical follow-up. Humerus fractures, there's going to be a number of these, so there'll be kind of a quick run through. Generally pretty uncommon in young people. It's going to be a really high energy trauma, probably higher than sport. Lower energy trauma is ground level fall with some of our older patients. And then again, axillary nerve is your most at risk. If you see a midshaft humeral fracture, pay special attention to the radial nerve because it wraps really close to the midshaft of the humerus. This is an older adult with a 3-part humeral head fracture. These actually do pretty well with just a sling and can be followed as an outpatient. And the sling actually helps a lot with the pain alone and can be discharged from the ER not infrequently, as long as their social supports are adequate and there's no other significant injuries. This is a greater tuberosity fracture. It's fairly well approximated. If it's less than 5 millimeters of displacement, these can be managed also with a sling. And then they can come out of the swing in 2 to 4 weeks as long as their pain is doing well. Early pendulum exercises are great. And then start doing some PT once you start to see a bony callus. This is someone who fell from a ladder, and this will be an upcoming theme. Christmas light decorations and ladders are a frequent source of my X-ray library, and that's unfortunately this gentleman had a significant glenoid injury here. It's a little hard to see, but it's significant articular involvement, and this person needs a surgical referral. It's mostly a reminder of just looking at the whole joint. Even though we're talking about humerus, we're also going to look at the glenoid. We'll look at the clavicle. We'll look at ribs. Anything else we can see. This is a fun X-ray. This is ultimately just a multi-part proximal humeral head fracture that is going to need surgery. This displacement, I initially thought might be dislocation. It's actually just massive hematoma formation causing some inferior migration. If you look down here, this is what an old midshaft humeral head or midshaft humerus fracture looks like. Several decades ago, there was theoretical concern that we were going to cause radial nerve injuries when they did RIF on these. So they allowed them to heal conservatively, and that's what happened to this patient. Now I think most of them are getting RIF. This X-ray is just a reminder of look at the whole X-ray, because here we caught just the edge of humeral shaft fracture. This patient presented the ED with shoulder pain, and even with this X-ray still described shoulder pain. They got a nurse-initiated order set X-ray from triage. And this lateral X-ray is the only one that caught the humeral head fracture. So sometimes it's better to be or the humeral shaft fracture. Sometimes it's better to be lucky than good. They still even weren't that tender in their mid humeral shaft, remarkably. So these I tend to put in a sling if they're non-operative. Even if they're operative and they can be discharged, I'll put them in a sling and then they'll get early follow-up with ortho. Early pendulum exercises can be really helpful. The ones that are going to go for surgery are 3+ part fractures, more than 5 millimeters or greater tuberosity displacement, or any fracture dislocations. The fracture dislocations probably are getting surgery on a much more urgent basis. Make sure you check your axillary nerve. It's really hard to get that deltoid motor to fire in somebody who's acutely painful, but I try to get them to see if they can make a muscle out of it, is usually the words I'll use. I make sure they have sensation intact. A posterior long arm splint is really helpful. For the mid-shaft fractures, if you hear somebody ask for a coaptation splint for any proximal humerus fractures mid-shaft, those are still described, but I think they're going away and much less common. I think they're really hard to put on, and I don't know that they're that well tolerated. So I tend to just do posterior long arm splints for these mid-shaft. We'll get an X-ray usually 1 or 2 weeks out, and then another 4 to 6 weeks, and I'm looking for bony callus formation and following them. Couple of bonus X-rays, since we're talking about humerus, supracondylar fractures. These are almost always going to require orthopedic consult. These tend to be in kids. The textbook will say that they're at risk of brachial artery entrapment if you reduce them. This X-ray actually had a kid who had a loss of pulses before the reduction and improved post-reduction. But all of these are going to require orthopedic referral. Very uncommon to see in older adults, but this person, again, supracondylar fracture, this needed surgery. another fall from a ladder. And then forearm fractures. This is always the one that I kind of have to remind myself about. Eponyms I find very challenging, but the Mugger mnemonic for the very testable Monteja and the Galeazzi fractures. The Mugger mnemonic describes the fractures. The Monteja has an ulnar fracture and the Galeazzi a radius fracture. The opposite bone is dislocated with these. We'll start with the Monteja. So what you'll see is a proximal 1/3 ulna fracture. The radius is pretty obviously dislocated. There is this described line, the radiocapitellar line. What you'll look at here is this line through the mid portion of the radius. It should come to the capitellum. If it does not come to the capitellum, then it suggests a dislocation. So when it's not obvious like this one, this really good lateral view will help you try to sort out if there's any dislocation of the radius. These can be attempted for reduction, but not infrequently. You're going to need some sort of surgical intervention, potentially even while they're in the hospital. Whereas this is a Galeazzi fracture, and these potentially can be reduced, though sometimes still need surgical intervention immediately. This is going to have a distal radius fracture in the 1/3 with dislocation of the ulna. This one is quite obvious. Some of them can be a little more difficult, and it can actually just be a DRUJ instability. And I hesitate to really say like DRUJ pain with motion is really helpful because it's obviously very painful when you move somebody's radius and ulna with this fracture. So what I really look at is what is the instability compared to the contralateral side. They're obviously probably going to hurt when you try to do any kind of piano key of those two distal bones. If I can get them reduced and restore anatomic alignment, then I'll put them in a sugar tongue splint and get them follow up and work with your surgical team on how they want to approach these. This is a radial head fracture, pretty subtle, small, non-displaced. These can be managed very clearly in the outpatient setting. You can put them in a sling, usually 3 weeks, but the sooner you can get them out of the sling, the better. They are going to lose some terminal extension. The sooner you can get them into range of motion, the better, because they'll get as much elbow extension as they can. This is a small coronoid fracture. This gentleman was a 4th of July type injury. He was sitting in a lawn chair and he was leaning backwards and he put his hand out and we think he probably dislocated, and then he described a really clear clunk when he stood up. So we think he probably reduced, and this coronoid fracture was what went with it. But fortunately, it was not a terrible triad since it's a small chip fracture, didn't involve the radial head. It was pretty stable. We splinted it and had him follow up. He actually did not end up needing a surgical intervention. This is really not going to be a sports-related injury, but worth mentioning since if you do any primary care, you'll probably see some of these. This is a distal radius fracture with an ulnar styloid. This one pretty clearly needs reduction, but if it can be reduced and get adequate reduction, can be managed non-operatively. But I think they're worth getting x-rays at 1 week and 2 weeks because some of these will get recurrence of this dislocation and end up needing an ORIF. If you can get them to be stable, you can cast them and see them in a follow-up. Tends to be those with more than 5 degrees of angulation, some say 15, and then 5 millimeters of radial shortening need a surgical intervention. Sorry about that. This is an x-ray of kind of more that classic kind of cup alignment of the distal radius and ulna, where we want to get to with the reduction. This one, you can just see this little subtle chip kind of buckle. She had a small distal radial impaction fracture, and these don't need any reduction at all. You can just splint them and have them follow up. They do very well. So carpal fractures, we'll talk about scaphoid fractures is probably the most common one. This is your scaphoid view where you've really exposed the scaphoid. Really critical to get in that acute wrist injury where they have snuff box tenderness. Unfortunately, it's negative at time 0 when you get it. So it's important to get a repeat x-ray at 10 to 14 days. CT and MRI are more sensitive, but pretty impractical. So it's probably reasonable to follow it with x-rays. I will suspect this in anybody with snuff box tenderness. I will say the counter side is if you push on the snuff box hard enough, it does hurt. So I'll always push on the unaffected side. Just ask, like, is there a symmetry to the patient? And say, oh yeah, there is symmetry. Then I think, okay, less likely, or versus more likely. But I'll put them in a thumb spike and have them follow up. And then here is a suspected non-displaced waist fracture. These can be managed non-operatively if there's less than 1 millimeter of displacement, but it's really critical to get them in a thumb spica. for 8 to 12 weeks until they are pain-free. And the reason for that, as a reminder, is that they have retrograde flow from the artery, and it's a watershed area. And they can get a really bad avascular necrosis. Like this patient who was a delayed presentation as an athlete from my follow-up or from my fellowship, who was competing collegiately, who had a wrist injury, played through it, wasn't getting better, and finally came to see us. I don't really know how he made it without seeing us, but he ended up having an AVN. He was really tender at the scapha lunate, so we got a clenched fist view, and I include that mostly so that you can see what a clenched fist view is, which really delineated it for us. I think it was because it was a more proximal scaphoid fracture, but unfortunately these are bad outcomes when people get AVNs. So I think it's really critical to splint these and then get that repeat X-ray. As a quick reminder, the clenched fist view, when you look for a scapholunate dissociation, you're looking for widening at this joint, looking for that Terry Thomas sign. Sometimes people call it David Letterman because it's been so long since anybody knew who Terry Thomas was. Most people are at least familiar with David Letterman, but it's that wide gap tooth appearance. This X-ray is just included as a bonus. This is a pisiform fracture. Pretty easy to miss because of the obvious distal radius fracture, and it's just a reminder that the second fracture is the easiest and most commonly missed fracture. This person fell from a horse, and they were actually managed non-operatively pretty well. They did meet with ortho because of the articular involvement, but did well. Wrist dislocations are really uncommon. There's really not a lot of complexity to these reduction techniques. You're just going to use a traction, counter traction. You probably need some degree of sedation. This here, you can see all the carpal bones are displaced dorsally off of the distal radius, and maybe angle, but maybe this ulna is dislocated, and there's a DRUJ element too. He fell off a roof hanging Christmas lights. He does have an ulnar styloid fracture hiding in there as well. Once you get them reduced, sugar tongue splint, be really careful with these exam and good return precautions, because if there's any hematoma or acute carpal tunnel syndrome, these can be pretty negative outcomes. So acute carpal tunnel syndrome, anything in the wrist, I really am examining for and giving a warning to the patient. Fortunately, pretty rare, but I've seen it. And they need to go to the OR for immediate decompression. Digit dislocation, unfortunately, don't have a lot of these X-rays in my library. Most of these either get reduced by the patient before they come to the ER or immediately by me or one of my colleagues. But typically we'll reduce these before getting X-rays. But this is one we recently had in our ED of a thumb dislocation. This positive arrow sign at this little kind of fleck. Never really did figure out what it was. It totally resolved on repeat X-ray. And there was really no ongoing symptoms, but we think it was probably a small chip fracture. But it was a really unclear donor site. But once you get them reduced, just a quick traction, counter traction, put them in extension with a splint. You can block them with a digital nerve block, which is fairly painful. So some of these actually are less painful if you reduce them, and the pain will go down almost immediately. So shared decision making with your patient about how do you want to approach it. A tuft fracture, these are really common crush injuries. I'll typically split these in extension for a few weeks. These do well. I don't typically get any repeat follow-ups unless there's any concern about healing. And then finally, this is actually a rotational injury of the middle phalanx. And these need to be splinted in extension, can be buddy taped, but I like extension. And I'll bring these back for repeat films to make sure that this doesn't displace and start to rotate, because it can cause a chronic deformity to the finger. If there's any kind of rotational or chronic deformity malunion, they're going to need to be referred to a hand surgeon to manage that. If they stay really stable and they heal well, then they may be managed conservatively. Thanks to Dr. Dylan Dean and Dr. Rachel Benson, a couple of my mentors and colleagues who've contributed to some X-rays to this library. I've got a couple of board questions if we have time. If you all want to give me a heads up if we have time, I can let the folks read them and we can go through them. So for this one, I think the answer, give me a second to switch it back, is C. So for these, any kind of first-time dislocation, I want to get a repeat neurovascular exam after reduction. We can immobilize in a sling, and then early pendulum exercises, and then schedule follow-up, get a repeat exam in a week, make sure that they're still doing well, that they haven't had a recurrence of their dislocation, and you can start answering some questions and trying to determine their return to play pathway. I think for just the sake of time, I'll read these out really quickly and then give the answers. So a 28-year-old mountain biker falls on an outstretched hand, presents with wrist pain and tenderness in the anatomic snuff box. Initial AP and lateral wrist radiographs are read as normal by the radiologist. The patient has reproducible snuff box tenderness bilaterally compared and a positive scaphoid compression test. So this is an axial load through the thumb, which reproduces pain. What is the most appropriate management? A, reassure the patient they have normal radiographs, rule out fracture, and then activity is tolerated. B, apply a thumb spica and arrange follow-up outpatient 7 to 10 days. Consider MRI or CT. C, refer immediately for operative fixation given high energy mechanism and snuff box tenderness. D, obtain a bone scan as it is gold standard for diagnosing occult scaphoid fractures in the acute setting. Or E, apply a short arm cast and discharge without imaging follow-up as scaphoid fractures uniformly heal with conservative management. And I think the answer for these is thumb spica, presume there's a fracture, get them back for follow-up. Some say 7 to 10 days, some say 10 to 14. And then if there's persistent pain and you have persistent negative radiographs, think about advanced imaging. And then question 3, 35-year-old rugby player is brought in after a tackle, fell onto an outstretched arm, was hyperpronated. He reveals pain, swelling, and deformity at the forearm. Radiographs demonstrate a fracture of the proximal 1/3 of the ulna with apparent displacement of the radial head. Which of the following best describes this injury pattern and its key management principle? A, Galeazzi fracture, which describes a fracture of the distal radial shaft, DRUJ disruption, managed with sugar tongue splint and follow-up. B, Monteja fracture dislocation, fracture of the proximal ulna with associated radial head dislocation. Orthopedic referrals required as most require surgical fixation. Essex Lopresti fracture or injury, proximal radial head fracture with DRUJ dislocation, treated with immediate RF in all cases. D, Colles, distal radius metaphyseal fracture with dorsal angulation, treated with closed reduction and casting. And E, terrible triad, early elbow dislocation, with radial head and coronoid fractures managed with elbow immobilization 5 to 10 days in early range of motion. And this one, I think, describes the Monteja fracture and then going to be an orthopedic referral pattern. The take-homes, in my opinion, are always get the orthogonal views because you're going to potentially miss subtle findings. Always document your neurovascular exam. Partner with your orthopedic surgeons and really figure out what they like to do. Some of these have some subtle distinctions in terms of how they're managed, and there can be areas of controversy. And I think having congruence in what you want to do with these is really key. Early mobilization prevents stiffness, except for when you want to intentionally cause stiffness. And then most scaphoid fractures are missed initially, so splint them, and then get follow-up in 10 to 14 days. What questions do you all have?
Awesome. Thank you so much. If anyone has any questions, feel free to put them in the chat. I have one question. How often do you find yourself reducing on the sideline? And are there any like very specific exam findings that will push you one way or the other to reduce that right then and there? And kind of piggybacking on that, what is your splinting material of choice?
Great question. Yeah, so when I'm reducing the sideline, thank you for saying that. If there's any neurovascular deficit, I really honestly don't care what the injury is. I'm going to try to restore anatomic alignment and see if I can get that neurovascular status restored. Because if I've got a neuro or vascular deficit, that's an acute emergency. The sensory one is tough because some people will have some distal sensory findings that are hard to link. If it follows a really clear nerve pattern and I think really truly a nerve's injured, then I'm going to go for it. If it's not clear, then I don't think that's as hard of a sign, but I wouldn't fault anybody for going for it. And then I generally am going to, I'm probably a little more aggressive. I'm going to try to restore an anatomic alignment for these, probably partly on the basis of I'm fairly comfortable with a lot of dislocations. And I realize even in the best of circumstances, I mostly cover high school sports. And so I don't have x-ray. I don't have any major tools with me. I'm going to have some sort of delayed in transport. Most of our EDs are going to have a lot of boarding. These patients are going to wait in the lobby. They're going to be in a lot of discomfort. And I can fix a problem quickly and probably try to restore some comfort as long as I have a really clear understanding of what I'm going for. I find like a sling and a SAM splint and a little bit of swath material I can pretty much jimmy anything I need out of it to temporarily. If I need something more complex, I can at least defer them onto a higher level of care, but I can buy myself time by getting something dislocated. But I've had patients where if I can get something dislocated, I can just say, hey, see me tomorrow. We'll see you in clinic and we can sort out where we want to go. If I think everything is really, truly okay.
Do you ever use vacuum splints and do you think they're better or worse or equal to the sand splint and wrapping?
I think the vacuum splints I have not used a ton of. I see them a lot in the ER, and there's a couple X-rays where that you can see them in the background. I think they're really well for immobilizing things that are clearly fractured, dislocated, unstable. So I have a lot of patients come in them. I get them off pretty quickly, and I either put in something stronger, or I will try to transition to a reduction really quickly in the ED. But I think they work pretty well. I think they're really good for immobilizing pain in the acute phase. So much of the pain I feel like is driven by the mobile structures that should not be mobile or the dislocated joint. And if I can reduce that, that is like having some opioid in the system. So it's really not a bad idea to have.
Awesome. Well, it looks like those are all the questions we have. Thank you again, Dr. Rudy, for being here with us this evening. And a reminder to everybody here, join us next week for our lecture series next Wednesday at 8:30 Eastern Time. Thank you.
Thank you for having me. Honored to be here.
Have a good night, everyone.